When the woman delivers, there is a drug you give to the woman so that the womb will contract, she will not bleed. Most health facilities conduct delivery, but they don't have that drug. When the woman starts bleeding, they will still don't have blood to transfuse. And they will say, yeah, go to Abakaliki. The woman will die on the way. Most women will hear that died at fetal. They have died even before coming. Yes. So we must have adequate supplies. Maternal healthcare system must be strengthened and community mobilized and dedicated to improve deliveries in birth clinics. We have community sensitizers now. Okay, we have community mobilizers that go to the community to make sure that women get access to the available health facility within that community. Universal health insurance coverage we have of women maternal deaths. FSHARE is around and is working in Ebonyi State. Okay, the former executive secretary is here. Now it's CMD. It's working. But we are looking at community participation. That is very important. Most of our women in the community die in the villages. They are not reported. That is why we need FSHARE. They are part of our community, and we tell them every time that this FSHARE must go to our rural women. They must be part of that. They must gain from that. Give incentives to health providers to motivate them to do their job effectively. Yes, this is one aspect of this present government has done a lot. Incentive to healthcare providers. You will see it because of this lecture. I did a training for the medical of that training. I saw that SUVs everywhere. I said, are they selling cars here? I said, no. It's these newly employed doctors that came with it. So when I saw it, I felt like putting my application to be employed. That I will get one of the SUVs. So it's a very big incentive. And they are well motivated and they are working. Educate and empower women and girls about maternal health issues. You see, our girls, we don't neglect them, but we are neglecting them. We don't count them. Okay, if you give me a choice, you see, I would prefer to have girls than boys. Sorry for other people. Because they are the crop of the family. They take care of the family. Unfortunately, we in the opposite direction. Look at the statistics. Our women and girls, they come close to thirds of the world of illiterates. More than 70% of the world illiterates are our women and girls. And also 70% of the world's poorest people are women and girls because we neglect them. We prefer to train the boys and leave them. And if you do that, you are perpetuating poverty. You are perpetuating maternal deaths because these women will not have access to good education. They will marry early and have a lot of complications during delivery. Their socio-demographic profile will be very poor. Their socio-economic enablement will be very poor. But if we educate our girls, they will marry late because they will go to the school. They will marry late and have fewer and healthy children who are more likely to attend school. Then we empower women groups, okay, to deliver political success. Launch professional well-informed advocacy groups to call for action for maternal mortality reduction. Implement streamlined and evidence-based maternal health interventions. We'll look at one in just 2 minutes now. We'll look at one of the evidence-based maternal health interventions, which we have been able to do. We implement evidence-based strategies to increase utilization of maternal health care services. We are doing that. Okay, we have community sensitizers, we have community mobilizers who go into the villages and talk to our women. Okay, to access available antenatal care, to deliver in a health facility. We have them. They're working now. Remove user fees for maternal health care services and provide transportation services. Transportation services are being provided now. Very well. We are looking into it. User fee removal is what we are still looking at. FSHARE is doing it, partially doing it. Okay, indirect. and we'll be dealing with only 2% of maternal deaths. But we have opportunities to achieve these preventive strategies. There are opportunities to achieve them. So many opportunities there, most of them have failed. For instance, short subsidy reinvestment and empowerment program, it has failed. National health insurance is not targeting the people that actually need it. I keep telling them, national health insurance, go to the community. Get these village women who are not, these are the people that will target the health insurance. Not CBN workers, okay, not NNPC workers. These are people that have access to national insurance, health insurance now. But out of all this, the most strategic response mechanism to strengthen these preventive mechanisms towards ending preventable maternal mortality is maternal and perinatal death surveillance and response. That is the most strategic mechanism towards preventing maternal deaths. We'll look at how it is. We'll look at how it is the most strategic response mechanism in preventing maternal mortality. In 2004, World Health Organization, in a landmark publication titled Beyond the Numbers, all countries that have not established medical audit system for the reduction of maternal death should do so without delay. The development of the document by the World Health Organization was a major breakthrough for the reduction of preventable maternal and newborn deaths. This medical audit process compels the health system to reflect on what might have gone wrong at each maternal death. Reflect on what might have gone wrong at each maternal death and respond to recommendation from the audit by preventing subsequent deaths. This audit system was non-existent in many countries, including Nigeria at that time. This medical audit system has undergone various transformations from medical to maternal death review and recently maternal and perinatal death surveillance and response. Now, what's the difference? Medical audits and maternal death reviews are retrospective analysis, retrospective. While maternal and perinatal death surveillance are real-time, continuous surveillance with immediate amelioration of the cause of death. What do I mean? Previously, what we do at death reviews, you may just say, let me look at maternal death from 2000 to 2010. And now you take an audit, so okay, the commonest cause was obstetric hemorrhage, followed by this. And then you analyze it and publish it. You are not doing anything to stop maternal death. You are just rolling out figures. But MPDSR is a real-time surveillance. You are looking, you just have a radar, looking at maternal death. Each time it happens, you look at it in real time, the immediate circumstances of that death. You have to analyze it. And when you finish analyzing it, you will ask yourself one question. Is this death preventable? You must answer that question. Is this death preventable? If it is, yes, it is preventable, then you have to answer the second question. Why does the woman, or why did the woman die? You analyze the circumstances of that death and you must answer two questions. Is it preventable? Yes. Why did the woman die? Now, in answering that question, you look at the circumstances of that death, analyze it, and see what you would have done that weren't done. That if it were done, this woman wouldn't have died. And based on that, you make recommendations which must be implemented. And when implemented, any other woman coming with the same circumstance will not die. That is what MPDSR is all about. And let's look at the definition. maternal and perinatal death surveillance and response. This is a continuous surveillance that links the health information system and quality improvement processes from the local to the national levels. And it includes the routine identification, notification, quantification, and determination of the cause and avoidability of all maternal and perinatal deaths, as well as use of such information to respond with action to prevent future deaths. That's what I've just refined. So what it involves is that you are continuously looking at the health facilities and even the communities looking for any maternal deaths. And when it occurs, it must be notified. It must be analyzed. The circumstances must be looked into. You should be able to answer a question whether that death was preventable. The technical subcommittee is the engine power for the MPDSR process. Who are the members of this MPDSR steering committee in the state? It's not hypothetical. Okay, these are membership of this Ebonyi State steering committee. So in the new guideline, the Honorable Commissioner for Health is the chairman of the MPDSR State Steering Committee. He knows that. He's the chairman. And we have Vice Chairman 1 and 2. Vice Chairman 1 is an obstetrician gynecologist, and Vice Chairman 2 is a pediatrician. I happen to be his Vice Chairman 1. And Professor Nire is the Vice Chairman 2, a pediatrician. But when you look at this, the composition of this committee, you will see that it's a very powerful committee. All directors in the State Ministry of Health are members of this committee. All executive secretaries and heads of programs are members of this committee. Plus other people from non-governmental organizations, like Nigerian Society Council, National Council for Women's Society, and other groups. So it's a very strong committee of the State Ministry. What have we been able to do since inauguration in January 2016? Initially, when it was inaugurated, we had a lot of engagement meetings to sensitize the people, sensitization workshops, to tell the people what has come to the state and what we want to do. And then massive training. These trainings are supported mainly by UNFPA. In 2007, massive training of all the health facilities, healthcare providers in Ebonyi State, and then training of all the monitoring and evaluation officers in the local government areas, the MROs in the hospital facilities, and then printing of the scorecards and dissemination of the scorecards to stakeholders. That in 2017, we still have massive training, and then development of the cost implementation plan for MPDSR in Ebonyi State. And of course, we started the review of the draft bill, MPDSR draft bill, which has been passed into law. We'll get to that. Having done all this massive training, what we did last was to pay advocacy visits to key stakeholders, the Excellency wife of the governor as at that time, okay, Honorable Commissioner for Health, and then the subcommittees were formed. What was our goal for MPDSR in Ebonyi State at that time? The primary goal was to eliminate preventable maternal and perinatal deaths. Eliminate it in Ebonyi State. That was what we set out to do. Eliminate them by obtaining and using information on each maternal and perinatal death to guide public health actions and monitor their impact. That is our major aim, to eliminate all preventable maternal deaths. But we have specific objectives. We need to pay attention to these objectives because that is what we do every day, every week, every month, every quarter, to notify and collect accurate data on all maternal and perinatal deaths. I have my phone here. Any maternal death anywhere in Ebonyi State, I will have an alert on my phone. Any maternal death anywhere, in any health facility, I'll have an alert on my phone. We'll follow the circumstances of that death. We'll review that death. What we're trying to find out is whether that death was preventable or not. If it was preventable, they have to tell us what happened. We'll look at the process. To analyze and interpret data collected from such maternal deaths, and use the data to make evidence-based recommendations for action to decrease maternal and perinatal mortality, and then disseminate our findings and recommendations to civil societies, health professionals, and decision makers to increase awareness about the magnitude, the social effect, and preventability of maternal and perinatal deaths, and to ensure that action takes place. That action is the response arm, that's the response strategy. You must make sure that action takes place. That action is that all your recommendations are implemented to prevent future maternal deaths. By monitoring and evaluating and reporting the implementation of the recommendations. That is our specific objectives in the state. We have a community committee of this MPDSR. What happens? In any facility, once there is a maternal death, it has to be notified within 24 hours. Such maternal death must be notified. You notify it by informing the officer in charge of that health facility and notifying the local government where that facility is domiciled. They must be notified within 24 hours. And within 72 hours of such death, the facility desk officer of MPDSR will get the case note of that patient and make a case summary of what happened. And then inform the chairman of that facility MPDSR committee. The chairman, within 2 to 4 weeks, will convene a meeting for maternal death review to look at the circumstances of that death. And as I said, during that meeting, they will use a summary of that death to answer some questions. One of the questions is the death preventable? If it is yes, why did the woman die? You must answer these 2 questions. And in answering why the woman died, you will raise some fundamental questions. You make some recommendations which should be implemented. That recommendation will now be forwarded to the state technical committee of MPDSR. At the state minister of health, we have a desk officer. The facility will now forward that recommendation to the desk officer of the state MPDSR. And the technical subcommittee meets every quarter to look at all those recommendations from all those health facilities where they have maternal deaths. Analyze the recommendations and feed them back to the community for implementation. It must be implemented. Otherwise, we are running around in circles. And then, of course, the monitoring and evaluation subcommittee of the MPDSR steering committee visit those hospitals to see to what extent those recommendations are implemented. That's our operational process. This is the coordination mechanism. How do we coordinate our activity? Any death in the community and within the primary health care facility are reported to the local government. The local government will now report to the state minister of health through the desk officer in the state minister of health. Whereas all deaths from the general hospitals and tertiary secondary health facilities are reported directly to the state minister of health. And all deaths from tertiary health facilities are reported directly to the state minister of health. The state minister of health, through MPDSR committee, will analyze those deaths and feed it back to the national level. That is the national MPDSR steering committee. At that national level, if all the state does this, it means that every death at the community, at the facilities are aggregated and the holistic data is gotten. So that any maternal mortality you are reporting is representative. That is how we coordinate. And this is the cycle of data of what we do. We look at the evidence. What is the state of maternal deaths? We collect the data, we analyze the data, we review the data, and make recommendation for action. Action, that's the response. Action. Recommendation must be implemented. If they are implemented, you review again. What is the evidence? Is the maternal death reducing? Is it static? Is it going high? You review again. You continue this cycle of data collection, reflection, and action until you record almost zero maternal mortality. This is what we do every day, every week, every month, every year, until we achieve what we are looking at. So, having done this, let's look at the current state of maternal mortality audit in Ebonyi State. What is the current state of maternal mortality audit in Ebonyi State? What have we been able to achieve through this MPDSR process in Ebonyi State? First is the MPDSR Ebonyi State Law 2020. The major landmark achievement is the passing into law of the Ebonyi State MPDSR Bill. It is now known as Ebonyi State Maternal and Perinatal Death Surveillance and Response Key Law 2020. Law number 21 of 2020, officially gazetted. Officially gazetted. So it's a Ebonyi State law. See, it is officially gazetted. It can be quoted. The highlight of the law is that it is now mandatory to report all maternal deaths in Ebonyi State. Mandatory. Irrespective of where the deaths occur, whether in our healthcare facility or at the community, it is mandatory to report all maternal deaths. Otherwise, that law, number 21 of 2020, will hold you accountable. I'm sure most of you don't know that. It is due to the astuteness of MPDSR in the Ebonyi State that that law was passed. Review meetings of the State Technical Committee and State Steering Committee. Regular, every quarter. All maternal deaths and perinatal deaths in all healthcare facilities in the Ebonyi State are reviewed. Recommendations for prevention of repeat avoidable maternal deaths are made and thereafter fed back to the facility for immediate implementation. Monthly supporting supervision visits to facilities to make sure that the recommendations are being implemented. When you make the recommendation and feedback to the facility, you follow them up. We have monitoring and evaluation subcommittee who visit the facility to make sure that our recommendations are implemented. This is our and feedback our recommendations to the facilities for implementation. These are sessions of the technical subcommittee meeting. This session must have been during COVID. You can see everybody wearing face masks. That's a technical subcommittee is held every quarter. This is the last one here. Okay, by my right is the second vice chairman, Prof Ibekwe.
And by your left is the woman there.
There is training and retraining of health workforce as the need arise. We do that. Because we discovered that most health facilities don't have manpower that are well trained. So what we do is that there is continuous training and retraining of the health workforce as the need arise. The last training was on March this year, March 10 to 13, 2024, for the newly recruited medical doctors posted to the 13 general hospitals in the state. The training was presidential, robust, and impactful. Currently, all the newly recruited doctors in the state have been trained on MPDSR processes. They have been trained. March this year, we trained them. These are sessions of the training. Okay, 3-day residential. Okay, that's yours sincerely there because of the training. That was where I saw the SUVs and I was tempted to apply for one. Currently, there is regular real-time report of any maternal or perinatal 190 public health facilities in the state. Real-time reporting. As I said, if any maternal death occurs now, it will report to my phone. They are reported in real time via phone calls, text messages, or WhatsApp group platform. These deaths are reviewed and recommendations to prevent future deaths are made. And then monitoring and evaluation subcommittee follow up to ensure that the recommendations are made. Based on that, there has been noticeable reduction in maternal mortality trends in Ebonyi State. I'll give you a typical picture of a quarterly review of what we did. What we are seeing here is a typical audit of what was done in one of our meetings. This is the third quarter review of 2022. I just use it as an example. You have the serial number there, you have the name of the health facility. We intentionally removed the health facility for anonymity. And then you have the maternal deaths, you have the perinatal deaths. The number of maternal deaths, the number that were reviewed. The number of perinatal deaths, the number that were reviewed. And then the total number of deaths. And then total number of delivery within the same period. We did it in the third quarter of that report. We had 170 out of the 190 health facilities presented their report to us for review. 170 health facilities in the state. Out of that 170 facilities who submitted their quarterly report, they had copy, WhatsApp, and digital copy. A total of 40 facilities held their monthly meetings because we also find out whether each facility held their meetings. Out of the 170 health facilities, 31 facilities reported maternal mortality. We had 7 maternal deaths within the period and 158 perinatal deaths, and a total of 165 deaths that quarter. During the same quarter, we had a total number of deliveries of 3,866 within the same quarter. So we have the record number of deliveries. If you ask us, we'll give you the data. Total number of deliveries within the same quarter in all our health facilities in Ebonyi State. So these are the indicators based on that review, third quarter review. At that quarter, maternal mortality ratio in the state stood at 181 per 100,000. Perinatal mortality stood at 40.8 per 1,000. Let's compare this with the global and our national figure. Nigerian maternal mortality currently stands at 512 per 100,000. And look at our review, third quarter review, 181. The global maternal mortality stands at 152 per 100,000. So we are almost chasing the global maternal mortality figure. We have gone beyond the nation. At the perinatal mortality, Nigerian figure at 41, our own is 40.1, the same thing. And the global 36. When we compare this from the figures we had before we started this project, the study done back in 2008, the maternal mortality ratio was 3,392 per 100,000. Very wonderful figure. In 2010, we did another study. It came to 902.7 per 100,000. It came down. But since we started this project, the maternal mortality has been coming down because of the processes we put in place. The current third quarter review was 181 per 100,000, very, very low because of the processes we are doing. This figure, however, is not to be quoted. It's a third quarter figure. We need to get a yearly figure for somebody to quote it as a Ebonyi State figure. So what are the outcomes based on our review every quarter? Maternal mortality ratio in the Ebonyi State has been coming down because of the MPDSR processes. Perinatal mortality has been coming down because of the MPDSR processes. The causes of maternal mortality are still known. Postpartum hemorrhage from our review is still the top. as causes of maternal mortality, followed by hypertensive disorders and complications of unsafe abortion, followed by sepsis. So as I said, it's still the same pattern. Based on our study here, it is still postpartum hemorrhage, that's bleeding. It is still eclampsia, hypertensive disorders, complications of unsafe abortion, and infection following delivery, genital infection. These are the 4 main causes of maternal death in Ebonyi State. And what we are doing currently is see how we prevent deaths from maternal, from obstetric hemorrhage, bleeding. Most of the women are bleeding because we don't have the drugs to contract the wound. It's as simple as that. The drugs. So we make these drugs available. That is one. 2, we don't have the requisite manpower to know how to and when to administer the drug. You don't administer it anytime you want. It is time at a particular time for it to be very effective. So that is why we are training a lot of them. On-the-job training, through monitoring and evaluation and supporting supervision. We'll get to that level. I'm sure in the next couple of years we'll start talking about hemorrhage. Implementable recommendations. We make sure that all recommendations are implemented because we visit the facilities to make sure that what we give them, they are doing it. Why are they doing it? We follow committee action plan. Any recommendation has a responsible person. You don't just put recommendation and leave it. There is a responsible person tasked to implement that recommendation. And there is a timeline for that implementation. That's why we follow it up. That's the response time. You must follow up that response time to make sure that those recommendations are implemented. That is actually what does the trick. So there must be a responsible person and there must be a timeline for that recommendation. Based on the enormous work done on maternal and perinatal death in the state, our work was part of the publication in a high impact journal, +1, sponsored by USAID. That article was titled, "It might be a statistics to me, but every death matters." They said, if you look at that, they said 3,398 maternal. You don't know what it means because it has not affected you. It's an enormous thing. So that was the title of that publication. It may be a statistics to me, but every death matters. An assessment of facility level maternal and perinatal death surveillance and response systems in 4 sub-Saharan African countries. It was a 23-page publication. And yours inside here was part of that publication. That study was done in 4 sub-Saharan African countries. Nigeria was part of that 4 sub-Saharan African countries. And in Nigeria, Ebonyi State was the state used for that study. And that study put Ebonyi State in the world map. Because that study, now the committee, USAID that sponsored it, wrote a recommendation letter to us for the magnitude of the work we are doing. There have been improvements in the healthcare delivery system in our facilities, infrastructure, and human resources for health. There is massive advocacy to improve healthcare infrastructure and human resources for health. There is rehabilitation of healthcare infrastructure and recruitment of health manpower. These 3 bullets have been done by this state government, present government of Ebonyi State. Rehabilitation of health facilities, recruitment of health manpower, massively. And the glory of our general hospitals are coming back. Right now, you can go to our general hospitals and access care. It wasn't used to be that previously. Thank you, Your Excellency. Raising community awareness on consciousness on the causes and prevention of maternal deaths. That's what we do. There is continuous community sensitization and awareness creation on the causes and prevention of maternal deaths. To have community engagement. There is continuous mobilization of pregnant women so that they can access care and deliver in the facilities within their community. We have radio jingles, health talks through the electronics, media, flyers, and announcements. I'm a regular visitor to EPDS because we talk there very frequently for maternal health issues. And then there is periodic advocacy visits to stakeholders in the health system. Honorable Commissioner for Health, still planning our next person visit. One from the governor of the state, local government chairmen, medical directors, OICs of health facilities, World Development Committee chairmen, and traditional rulers. We have engagements with all these people based on where we are operating. We engage them on issues pertaining to maternal health. We have ongoing projects, one of which is electronic reporting of maternal and perinatal deaths. Previously, we used to report maternal perinatal deaths through hard copy. We are now going into digital electronic reporting. Health facilities, to local government, to states, and finally to the federal level, digital reporting. As I said, any death within our facility comes to my phone as an alert. My sense is at the forefront, and some health workers have been trained on e-reporting, and some health facilities have already migrated to this platform. Community-based MPDSR. Community-based MPDSR is that any death within the community must be investigated, and circumstances of that death known, and recommendations made to prevent future death. The implication is that if you die in the community, we can examine the circumstances of that death, and we can even issue you death certificate, even when that such death is not in the health facility. It has never been like that before. We have an ongoing research now. What we are doing is evaluation of health workers' attitude towards the implementation of maternal and perinatal death surveillance and response scheme in Ebonyi State. We are looking at that so that we see where to come in. This project is not without challenges. Inadequate report from health facilities. The figure I showed you, out of 190 health facilities, we have 170 reporting. Out of that 170, we have 40 facilities reviewing the deaths, having their monthly meetings. So it's a challenge, and we are still offering supportive supervision to help them. Lack of funds for various activities of MPDSR processes, and poor documentation. When we go for supportive supervision, we notice that the tools we are using are not being used, so we have to support them. Poor documentation, and then inadequate human resources for help and frequent transfers. You will train some staff. You come for supportive supervision and train some staff on some skills. In this facility, by the time you visit them next time, they will say that person you trained has been transferred. So you start again. So it's a very big challenge to us. Let me conclude. As the world approaches the midpoint of the Sustainable Development Goal era, there is time to mobilize and invigorate global, regional, national, and community-level commitment to wide-ranging objectives and targets, including to renew the commitment to end preventable maternal mortality and to ensure that women not only simply survive the pregnancy, but are healthy and thrive. In the short term, provision of services that are adequate, accessible, available, affordable, and user-friendly, and the availability of adequate healthcare providers, as well as equipment and structures to take care of emergency obstetrics, are areas that need emphasis and urgent attention. In the long term, it is a combination of education, improvement in women's status, career opportunities, and full access to family planning information and services that will have the highest impact on maternal mortality. Maternal death reviews in health facilities and verbal autopsies in communities and response feedback mechanisms must be an integral part of all maternal deaths. And this is what we are doing. Finally, every maternal death must count. Everyone. No maternal death is higher than the other. Everyone must count through routine identification, notification and reporting, quantification and determination of cause of death, review of such death, and response for action. That response feedback is very important for the successful conduct of APDSR, not just in a state, but in Nigeria. This strategic mechanism will no doubt help to reverse the burden of maternal deaths and possibly eliminate preventable maternal mortality. Thank you very much. Let me once again thank the Vice Chancellor most graciously for giving me this opportunity. I'm very grateful, sir. I thank the Program Chancellor and members of Council here present of Ebonyi State University. Today, the principal officers of the university, members of the University Senate and the university community here present, the staff and students of College of Health Sciences of Ebonyi State University, making our time to grace this occasion. My mentors and senior colleagues here present, whose idea influenced my academic and scholarly achievements. I will not fail to mention Professors Adema Eze, Zumba, Ona, and also Professor Chudere, Ilabache, Dr. Sakwe, and John Okaro of blessed memories. I owe these men my high regards. I am grateful to the government of Ebonyi State and the State Minister of Health for giving issues pertaining to maternal and child health in the state, and particularly the passage of APDSR bill in the state, which made maternal and perinatal death a reportable event, for giving it very good attention. I give credence to the development partners and donor agencies that have assisted in this program in the state. I thank in particular the Integrated Health Project, IHP, supported by USAID, for the massive support to APDSR activities in the state. In so many trainings, hosting of technical and steering committee meetings, supporting supervisions, logistics, and technical support. Without you, we would not have achieved much. I'm also to SOGON, UNFPA, Rotary International, and other donor agencies and program officers that have supported this project in one way or the other. The real-time identification, notification, and review of maternal deaths would not have been possible without the commitment of the State APDSR Steering Committee and Technical Subcommittee, astuteness, and with support from the other health facilities. I admire your determination and doggedness, but it's not over until it's all over. In a special way, I appreciate my wife. I'm able and beautiful wife. A source of inspiration to me. She has made so many positive impacts in my life and in my academic and professional pursuits. She would have been here today, but for some exigencies. But she is following this program live from the United Kingdom. And to my wonderful children there, I'm not sure much food because they can stand up for the condition. Yeah. Characterized? Yeah. Yeah, but very, very thank you very much. My very special appreciation to my organizing committee and my committee of friends, headed by Dr. Adazion, who is also the chairman of this. Acknowledge ceremonial committee. I don't like that for the potential organization of today's event. And to many others. Too many to mention. The Ibekwe family from Ozugbo, they are here. And well-wishers, professional colleagues,